The current challenge in our obstetric practice is managing the peri-viable preterm births. Now, this peri-viability is actually a challenge because the baby has crossed the age of viability defined by our country, and that is 20 weeks of completed gestational age. And naturally, our aspersions and expectations of this baby going to get and land into live birth is definitely heightened. We have already done the anomaly scan, everything is perfectly normal, and now we are just hoping that we are able to deliver this baby at least beyond 34 weeks of gestation. And lo and behold, patient presents around 20 or maybe before 25 completed weeks or 26 weeks with the symptoms of preterm birth. And then we are in a dilemma, to be or not to be. Should we do everything to help this baby survive or salvage, or should we just ask the patient to accept the malady and allow this pregnancy to finally deliver? But then there has been an obstetric care consensus which has been published by the ACOG and the SMFM, and they have talked about certain clinical management guidelines of pregnancies in this peri-viable age group. And what did these guidelines summarize? That the survival of the neonates around this particular age group can be improvised or brought about by the correct and the optimum use of antenatal steroids, the tocolytic agents, appropriate antibiotic administration, offering a cesarean birth if necessary for a better outcome of that baby, and of course following and establishing local protocols of perinatal care, neonatal resuscitation and intensive care support. Similar findings were observed in a survey of ACOG members that reported on the impact of provider and institutional factors on counseling and decision making in the care of peri-viable pregnancies. And it's true, because we have to definitely consider this particular factor. If I am going to deliver this baby now by a cesarean section, am I immediately going to have an access to a good neonatology facility which will be able to help survive this baby? So this rational decision making is essential, because you are going to land up in making this mother morbid by giving her a cesarean section scar, and there may not be an optimum baby outcome. So this calls for a proper counseling, consensus if necessary, taking another colleague on board for that counseling session, taking a second opinion, speaking to the family, and then taking your decisions. But these are the various aspects which have been found to improvise, and therefore it is imperative that we are well versed with the use of all these modalities properly.